Good morning everybody. I am Dr. Nitin Joshi, Professor in Urology with teaching experience of 25 years. Today we will discuss very basic topic, and that is glomerular filtration rate, which is asked in theory as well as it will be asked in practical exam. Kidney is responsible for maintenance of homeostasis by process of excretion by formation of urine. The formation of urine means actually cleaning or cleansing of the liquid part of blood, that is plasma. Unwanted, toxic, harmful substances which are dissolved in plasma are excreted by kidney in urine. The first step in formation of urine is glomerular filtration. Now what is actually glomerular filtration? That is when the blood is flowing through the glomerular capillaries. The plasma, that is liquid part of blood present in the glomerular capillaries, is filtered across the glomerular membrane into a potential space between the visceral and parietal layer of Bowman's capsule, which is called as Bowman's space or glomerular space. The process is called as glomerular filtration, and the product which is formed is called as the glomerular filtrate. Now this glomerulus and Bowman's capsule together is called as renal corpuscle or Malpighian corpuscle, which acts as a good filter and is responsible for glomerular filtration. The process of formation of glomerular filtrate is similar to that of formation of tissue fluid or interstitial fluid in between the interstitial spaces all over the body. But this tissue fluid or interstitial fluid is formed by the Starling's hypothesis. In case of kidney, the process of formation of glomerular filtrate takes place by a spatial and structural and functional adjustment, and that most important structural and functional adjustment is that in the glomerular capillary bed, there is development of high hydrostatic pressure. That is, in case of glomerular capillary bed, the hydrostatic pressure which is present is almost double that of rest of the capillary bed of the body. The hydrostatic pressure present in the glomerular capillary bed is about 45 to 60 millimeter of Hg, while that of rest of the body is only about 25 to 35 millimeter of Hg. And this high hydrostatic pressure, which is a driving force present in the glomerular capillary bed, is achieved because of one, that is renal artery is a branch of abdominal aorta. It is a direct branch, and abdominal aorta is a high pressure system. Secondly, the high renal blood flow, that is about 22 to 26% of the cardiac output passes through both the kidneys per unit, when the cardiac output is about 5 to 5 liters of the cardiac output per minute. So 2 to 2.6 million nephrons of the two kidneys receive about 1.2 to 1.3 liters of blood per minute out of 5 to 5 liters of cardiac output. Now glomerulus, which is a tuft of capillaries, it is about 35 to 40 loops, and it is present between the afferent and efferent arteriole. So it is purely an arterial system, that is high pressure system, that is absence of low pressure venous system. Now this glomerulus, which is tuft of capillaries, is situated just proximal to the efferent arteriole, and therefore the blood flowing through the glomerulus is affected by the resistance offered by the efferent arteriole. The afferent and efferent arteriole shows difference in the diameter as well as in the structure. That is, afferent arteriole is wide in lumen and thick walled, while the efferent arteriole is narrow and thin walled, as a result of which the efferent arteriole is responsible for offering more resistance to the flow of blood passing through it and hence through the glomerulus. As a result, it acts as a high driving force, and thus overall effect is high hydrostatic pressure in the glomerulus, which is a driving force which is responsible for filtration of fluid from the capillaries across the membrane, and thus the glomerulus acts as arterial end of capillaries. Overall effect, this glomerulus and the Bowman's capsule is absolutely well suited to act as a filter. This filtrate which is formed gets accumulated in a potential space between the visceral and the parietal layer of Bowman's capsule, which is called as the glomerular space. Now, the actual process of glomerular filtration takes place across glomerular membrane, and it consisting of the three layers from inside out. The innermost layer is the endothelial layers of the capillaries of the glomerulus resting on the basement membrane. Second layer is the basement membrane, which is formed by the fusion of the two layers. The one basement membrane on which the endothelial cells of the glomerular capillaries are resting, while the second layer is of where the pedicles of the podocyte are resting. That is, the visceral layer of the Bowman's capsule is consisting of the single layer of the epithelial cells, but these epithelial cells are modified in such a way that they show a cytoplasmic extension which is called as the foot process or pedicle, and the cell with the pedicle is called as podocyte. So actually the pedicles or the foot processes are resting on the basement membrane. So on the basement membrane, from one side there are endothelial cells of the glomerular capillary, while from the other side there are foot process or the pedicles. Now, important point is that the endothelial cells of the glomerular capillary are modified. They are fenestrated. That is, they are having holes or pores, and the size of these holes and pore is such that it allows on the passage of water and water-soluble small molecular weight substances like glucose and amino acid, but does not allow the passage of large molecular weight proteins, RBCs, WBCs. Similarly, in between the food processes, there is what is called slit. This slit size of this is also such that it allows only passage of water and water-soluble small molecular weight substances, but does not allow passage of large molecular weight substances like proteins, RBCs and WBCs. Overall effect is that the glomerular membrane across which the filtration takes place is selectively permeable. That is, it allows only passage of water and water-soluble small molecular substances like glucose, amino acids, vitamins, minerals, but does not allow passage of proteins, RBCs and WBCs. As a result, it results in the formation of ultrafiltrate. So ultrafiltrate is because of two things, that is selective permeability of the glomerular membrane and high hydrostatic pressure or high pressure bed in the glomerular capillary. Overall effect is that there is formation of ultrafiltrate. Ultrafiltrate is nothing else but the presence of all the constituents of plasma except the large molecular weight proteins, RBCs, WBCs. Thus, the glomerular membrane is responsible for formation of ultrafiltrate, and because of this formation of ultrafiltrate, kidney is able to perform important function of excretion of the waste products of protein metabolism, as well as responsible for maintenance of fluid electrolyte acid-base balance, hence blood volume and blood pressure. Now we will come to the important function and parameter, that is glomerular filtration rate, because the most important function of the kidney is glomerular filtration rate. Single nephron glomerular filtration rate. What is single nephron glomerular filtration rate? The rate of filtration of plasma across the glomerulus of single nephron is called as the single nephron glomerular filtration rate, and sum of all single nephron glomerular filtration rate is total GFR, which is the most important function of the kidney and reflects the overall kidney function. Now, what is this actually glomerular filtration rate? We have seen that the kidney is having significantly high blood flow, and which is about 22 to 26% of the cardiac output per minute, and that is 1.2 to 1.3 liters of the blood passing through both the kidneys per minute. Out of this 1.2 to 1.3 liters of blood passing through both the kidneys per minute, about 120 to 125 cc of fluid is filtered across the glomeruli of all the nephrons of both the kidneys. And so the glomerular filtration rate is defined as amount of fluid filtered across the glomeruli of all the nephrons of both the kidneys per unit time. And so normally the glomerular filtration of both the kidneys per unit time, that is per minute, is about 125 cc per minute. When the per unit time, instead of minute, if it is a day, that is 24 hours, then it is 170 to 180 liters of glomerular filtration rate across both the kidneys per unit time, that is per unit 24 hours as a unit. Now, mechanism of formation of glomerular filtration rate can be explained by the formula GFR is equal to effective filtration pressure into the KF, that is filtration coefficient of glomerular membrane. Now, effective filtration pressure is equal to driving force minus the retarding force. Now, the driving force is actually the hydrostatic pressure gradient across the glomerular membrane, while the retarding force is colloid osmotic pressure gradient across the glomerular membrane. The hydrostatic pressure gradient across the glomerular membrane is actually the hydrostatic pressure in the glomerular capillaries minus the hydrostatic pressure in the Bowman space. Now we have seen that the glomerulus is a high pressure system, and that is hydrostatic pressure is of 45 to 60 millimeter of Hg, while because of filtrate there is development of pressure in the Bowman space, and that is 10 to 15. So 45 to 60 millimeter of Hg minus 10 to 15 is the hydrostatic pressure gradient across the glomerular membrane minus the colloid osmotic pressure gradient. Now what is this colloid osmotic pressure gradient? Colloid osmotic pressure is exerted because of plasma proteins and particularly the albumin. Now the colloid osmotic pressure in the glomerular capillaries will be same as that of the colloid osmotic pressure anywhere in the capillary of the body, and that is 25 mm of Hg. And we have seen that glomerular membrane normally is impermeable to large molecular weight substances like proteins, and so in the glomerular filtrate there is no albumin, there is no proteins, and so the colloid osmotic pressure gradient is 25 minus 0, and so overall effect is that about 45 to 60 minus 10 to 15 minus 25, so the effective filtration pressure is 10 to 20 millimeter of Hg, while the Kf, that is filtration coefficient of glomerular membrane, is dependent on the two factors, and that is the surface area or volume of the capillary bed into the permeability of glomerular membrane. Now the studies have shown that normally this Kf, that is the filtration coefficient of glomerular membrane, is 12.5 cc per minute per mm of Hg. So 12.5 into effective filtration pressure, that is 10, becomes 125 cc per minute. Now if you see that this glomerular bed surface area in turn is dependent on what is called as glomerular mesangial cells. Around the glomeruli there are special cells called mesangial cells which surround and support the capillary loops, and these mesangial cells are having contractile property. As a result of contraction, they can distort and they can reduce the surface area. So when they encroach or they distort, this results into reduction in the surface area of the glomerular capillary bed, resulting into decreased Kf and hence decreased glomerular filtration rate. Next factor on which the Kf is dependent is the permeability of glomerular membrane. Now this permeability is increased in case of hypoxia, anoxia, toxic metabolites, while this permeability is decreased because of the thickening of what we call as glomerulosclerosis. In case of the RAS system, that is the angiotensin II of the RAS, both the factors, that is the surface area of capillary loops as well as the permeability of the capillary, is affected. that is angiotensin 2, is responsible for upregulation of certain growth factors and the cytokines. These growth factors and cytokines act on the glomerular mesangial cells. They responsible for increased number and size of the glomerular mesangial cells. Because of the increased number, they result into distortion and the encroachment of the capillary loops, resulting into decrease in the surface area of the capillary loop, hence decreased KF, hence decreased GFR. Also, these mesangial cells are responsible for increased synthesis and deposition of extracellular matrix. As a result of accumulation of excess extracellular matrix, there is thickening and decreased permeability of the glomerular capillary, resulting into glomerular sclerosis, thus resulting into KF, thus resulting into glomerular filtration rate. Now will come the factors which determine the glomerular filtration rate. The most important factor on which the glomerular filtration rate is dependent is renal blood flow. That is, glomerular filtration rate is directly proportional to renal blood flow, because as the renal blood flow increase, it results into increased driving force, that is increased hydrostatic pressure, hence increased filtration, and hence there is increased glomerular filtration rate. But this renal blood flow in turn depends upon the state of dilatation or constriction of afferent arteriole, because afferent arteriole breaks into the 35 to 40 loops of the capillary. So when there is a dilatation of afferent arteriole, there is wide lumen, therefore increased blood flow resulting into increased hydrostatic pressure, hence there will be increased filtration across the glomeruli and hence increased glomerular filtration rate. The dilatation is maintained normally because of one, that is atrial natriuretic peptide, dopamine, endothelin derived nitric oxide, and the prostaglandin E2. Now clinical significance. The non-steroid anti-inflammatory drugs, they are responsible for inhibition of prostaglandin synthetase, resulting into decreased synthesis of prostaglandin E2. Because of decreased synthesis of vasodilatory prostaglandin E2, there will be unopposed action of vasoconstrictor substances like noradrenaline, angiotensin 2 as well as endothelin on the afferent arteriole. This results into decreased lumen, decreased blood flow, decreased hydrostatic pressure, hence decreased glomerular filtration. And so patient who is having compromised renal function, the use of non-steroidal anti-inflammatory can result into precipitation of acute renal failure. While second important application, that is whenever there is persistent hypotension, particularly in septic shock because of gross vasodilatation, then there can be end organ damage, and because of decreased renal perfusion there can be renal shutdown. But if we give the dopamine drip, then in case of the dopaminergic action on the dopaminergic dose, it will result into the action on the afferent arteriole. This afferent arteriole dilatation will result into the increased blood flow to the kidney, that is increased blood flow through the feeding glomerulus, and hence in spite of low BP there will be increased hydrostatic pressure across the glomeruli, thus maintaining the glomerular filtration rate. The constriction of the afferent arteriole is because of angiotensin 2, then noradrenaline, prostaglandin F2, platelet derived factor, and endothelin. Kidney has one important property which is very very important, and that is called renal autoregulation, which is also as a short note. And this property means the ability of kidney to adjust its renal blood flow in spite of wide variation in systemic blood pressure. Because of the adjustment of this renal blood flow, in spite of variation in systemic blood pressure, maintains the glomerular filtration rate and hence the renal function. And this renal autoregulation in turn is dependent upon the tubuloglomerular feedback mechanism. Now the next factor on which it depends is the driving force, that is the transglomerular or intraglomerular hydrostatic pressure, which in turn depends upon one, what we have seen is renal blood flow, that is state of dilatation of afferent arteriole. Second, that is systemic blood pressure. both, that is dilatation of afferent arteriole and normal blood pressure, will responsible for increased blood flow, hence increased hydrostatic pressure and increased glomerular filtration rate. Also, the transglomerular hydrostatic pressure also depends upon the state of the constriction of efferent arteriole. So, efferent arterial constriction will result into increased transglomerular hydrostatic pressure because there is increased resistance to the flow of blood passing through the efferent arteriole, which gets transmitted to the glomerulus. Now, angiotensin II of the renin-angiotensin-aldosterone system has got preferential action on the efferent arteriole and is vasoconstrictory. And so this is very important in case of the renovascular hypertension, or where there is clinically significant renal artery stenosis resulting into decreased blood flow, which result into stimulation of renin-angiotensin-aldosterone system. Because of this preferential action on the efferent arteriole and vasoconstriction, there will be increased resistance to flow resulting into increased driving force, and hence in the renovascular hypertension, though there is decreased blood flow, there is increased transglomerular driving force, thereby maintaining glomerular filtration rate and renal function. And hence, if you give the angiotensin converting enzyme inhibitors, which will prevent the availability of angiotensin II, that is conversion of angiotensin 1 to angiotensin II, or angiotensin receptor blockers, they will block the action of angiotensin II, as a result of which the selective vasoconstriction of efferent arteriole, which is important for maintenance of glomerular filtration, will be avoided, as a result of which there will be decreased glomerular filtration, and so by using this ACE inhibitor there will be sudden precipitation of renal failure. Now, next factor on which it depends is the retarding force, and is the colloid osmotic pressure. Now, colloid osmotic pressure, as we have seen, it depends upon the plasma proteins and hemoconcentration, that is whenever there is fluid loss, dehydration, hemoconcentration results into increased colloid osmotic pressure, increased retarding force resulting into decreased filtration, and hence in dehydration there will be decreased glomerular filtration. On the other hand, when there will be hypoalbuminemia from any cause, as for example nephrotic syndrome in our urology practice, or gross proteinuria from any cause, then in that case, because of hypoalbuminemia, it will result into decreased oncotic pressure, as a result of which there will be increased glomerular filtration rate. Next is the, again, one more factor which determines the glomerular filtration rate, and that is hydrostatic pressure in the glomerular space. Whenever there is increased hydrostatic pressure, normally it is 10 to 15 mm of Hg, but if it increases, it prevents the filtration, and this is classically seen in obstructive uropathy from any cause like the posturethral valve, BPH, stricture, bladder neck contracture, PU junction obstruction. It results into increased pressure, that is the hydrostatic pressure in the glomerular space, prevents the filtration, and hence there will be decreased glomerular filtration rate. The other factor which is important is aging, which results into glomerular sclerosis, resulting into decreased glomerular filtration. Now, since glomerular filtration rate is the most important kidney function, estimation of glomerular filtration rate is very important, and normally the tests which are carried out are one, that is the renal clearance. Out of that, the most ideal is inulin clearance, second is the creatinine clearance, and third, that is the renal scintigraphy. And by filtration, the agent which is filtered, pharmaceutical agent, is the DTPA. So DTPA scan for the estimation of GFR. The plasma markers which can be used are the serum creatinine, serum urea, and serum cystamin. There are various formulas and mathematical calculations one can calculate, with the help of which, by using the serum creatinine as the marker, one can get the estimated GFR up to the almost near GFR of the patient, which is very important from clinical point of view. Thank you very much.